my name is Mark Pegram. I'm a professor of medical oncology at the Stanford University School of Medicine, Palo Alto, California.
And good morning, I'm Garrido-Castro. I'm a breast medical oncologist at Dana-Farber Cancer Institute in Boston and director of the triple-negative breast cancer research there in the breast oncology division.
And we're here today at the ESMO meeting in Berlin. And there's been some breaking news in the triple-negative breast cancer space at this meeting. Can you tell me, first of all, what is triple-negative breast cancer, to start with?
It's a very important question. So triple-negative breast cancer is essentially called by what it doesn't have, right? So when breast cancer is first diagnosed, there are those three markers that we look for that help give information about prognosis, but also about the right treatment options for every patient. Those three markers that we've traditionally looked for are the hormone receptors, the estrogen and progesterone receptor, and the third is HER2. And so when all three are lacking, that's what we call it, triple-negative breast cancer.
Sure.
It's about 10 to 15% of all breast cancers.
And what about those patients that have very low levels of steroid receptors with the new ASCO-CAP guidelines with a cutoff of 1%? Do you believe that the biologic behavior of those ones that are maybe 5 or 10% ER expressing, are they the same as triple-negative, or are they more like hormone receptor positive disease?
It's a great question. So there have actually been several retrospective studies that have looked at this, right? Both from a clinical perspective, clinical pathologic features, and then also from a genomic, from a tumor biology standpoint. And in fact, from a molecular point of view, they tend to be more similar to the triple-negative breast cancers. There's more prevalence of basal-like tumors within the hormone receptor low HER2 negative group, and they also tend to behave in the clinical setting more similar to triple-negative breast cancers.
But for clinical trials, which definition is usually used? Probably the ASCO-CAP definition for most trials.
For most trials,
speaking,
yes. But it brings up a very good question of whether we should be expanding that. And I think in several, there are some studies, investigator-initiated studies as well, that use a more lenient cutoff, right? That use 5 or 10% to allow those hormone receptor low HER2 negative breast cancer
And
patients.
even if the cutoff in a particular protocol might have been the 1% cutoff, are practicing clinicians, are they doing the right thing if they kind of extrapolate that to a 5% ER case? Is that okay?
That is an excellent point, and I think very also relevant to the studies that we're discussing here today at ESMO, because the definition that was used was the ASCO-CAP guideline of 1%. And so if we think about these hormone receptor low HER2 negative tumors very similar, that they're very similar to triple negatives, then perhaps we could be extrapolating these findings. And we also have data for ADCs for hormone receptor positive HER2 negative breast cancer. So that's an interesting point of discussion. I think it's something that's not been addressed with either of the ADC trials presented here.
Do you anticipate this might be any issue with payers? Are they looking so focused at the definition of triple negative that they're going to get stumbled by whether you have a 5% ER or 3% ER, et cetera? Is that going to be a problem, or?
I don't know.
Yeah.
That's also it's a great question. I don't know.
Okay.
One thing that I would point out is that sometimes, for example, for clinical trials, there might be a definition, right? If a patient has hormone receptor positive expression, any positive expression, they must have received certain lines of therapy before they're eligible for that clinical trial, right? Yeah. And so for a patient who has been consistently over time hormone receptor low HER2 negative, if they haven't received endocrine therapy because the treatment has followed more of a triple negative paradigm, then that plays a role also, right, in terms of the types of therapies that they've received previously and how that is considered and interpreted in the context of the guideline recommendations and label, right?
Stands to reason. Thank you for that. Now, tell us about the exciting data from the TROPION-Breast02 study that was just presented here at ESMO.
Yes, no, it's been an exciting ESMO with a lot of data in the triple-negative breast cancer space, and I think stepping back, just taking one step back, for metastatic triple-negative breast cancer, chemotherapy has been the mainstay of treatment for many years, right? And in truth, we've seen relatively modest improvements in overall survival over time compared to other breast cancer subtypes like HER2 positive or ER positive HER2 negative breast cancer. And so over the past few years, there have been now approvals of antibody-drug conjugates, immune checkpoint inhibitors that have significantly improved overall survival. And so now we have 2 antibody-drug conjugates that are currently approved for metastatic TNBC. Sacituzumab govitecan, which targets Trop-2, and trastuzumab deruxtecan, which targets HER2 for the about 40% of patients with triple-negative breast cancer who have HER2 low tumors. And these two antibody-drug conjugates are approved in patients who have received prior systemic therapy,
Right.
essentially in the second line and beyond for metastatic TNBC. And they've improved outcomes compared to standard chemotherapy. And we've also seen some additional data in pre-treated metastatic TNBC for one of the newer Trop-2 ADCs, datopotamab deruxtecan, right, Dato-DXd. And from the PAN-201 phase 1 study, we already saw that in a topoisomerase 1 inhibitor naive patient population, the median PFS was 7.3 months. With SG, we've seen improvements in both PFS and overall survival in a randomized phase 3 study in the ASCENT trial that led to the approval in its current indication for TNBC.
Right.
And so with that comes the question of, can we use these antibody-drug conjugates earlier as upfront therapy in the first-line setting? And so that brings us to the two studies that were presented here at ESMO. And so two randomized phase 3 trials, ASCENT-03 comparing sacituzumab govitecan to chemotherapy of physician's choice, and TROPION-Breast02 comparing datopotamab deruxtecan to chemotherapy of physician's choice in the first-line setting for patients with metastatic triple-negative breast cancer who are not candidates for immune checkpoint inhibition, primarily patients with PD-L1 negative tumors.
And what percentage would that be that are not candidates for IO?
So about 65% to 70% of patients with triple-negative breast cancer, metastatic triple-negative breast cancer is
So
PD-L1
majority.
negative. Yeah,
Yeah.
the majority.
And what is Trop-2 exactly?
So Trop-2 is a calcium signal transducer in the membrane, that a transmembrane protein that is overexpressed in many different cancer types, but specifically in breast cancer and in triple-negative breast cancer, there tend to be high levels in about 90% of TNBC. And so some of these new antibody-drug conjugates like sacituzumab govitecan and datopotamab deruxtecan target Trop-2.
Why don't we measure it? Why don't we have a companion diagnostic?
So also a very good question. And in the studies that have been conducted to date in breast cancer and metastatic breast cancer, looking at levels of Trop-2 expression, compared to chemotherapy in randomized clinical trials with the Trop-2 ADCs versus chemotherapy, even patients with low levels of Trop-2 expression measured by immunohistochemistry as assessed by a pathologist, even with low levels, patients appear to derive more benefit from the Trop-2 ADC than chemotherapy. And so this has not yet been a predictive biomarker of response to the Trop-2 ADC to identify candidates. And that's why we don't test for Trop-2 expression specifically in breast cancer. What has been interesting is we've seen in lung cancer, for example, new methods, computational methods of scoring the Trop-2 expression. And there's now a companion diagnostic for datopotamab deruxtecan in lung cancer with the quantitative continuous scoring of Trop-2. And so there perhaps may be better methods of assessing Trop-2 expression or other targets as well that may help refine selection of an ADC for patients. So much more.
Now, I understand there are subtle differences in study design between ASCENT-03 and TROPION-Breast02. Can we just kind of review some of the nuances in terms of the study designs and what the primary endpoints and in one case, co-primary endpoints were?
So there are some very important differences in the design, right? So ASCENT-03, patients were randomized to receive either SG or chemotherapy physician's choice. Those patients who were on the control arm at the time of progression, they could cross over to receive SG. That was provided by the study. And we know that SG in the second line and beyond has demonstrated PFS and OS benefit.
Right.
In contrast, in TB02, patients were randomized to receive Dato-DXd or chemotherapy physician's choice, but we don't have randomized phase 3 data for Dato-DXd in the second line and beyond, and there was no crossover in that study. Importantly also, the chemotherapy selection, the options of chemotherapy were different between the studies. So for ASCENT-03, there was the option of either a taxane or carboplatin plus gemcitabine. And in TB02, most patients received a taxane if they had de novo metastatic disease or if they'd received prior taxane but had a DFI of greater than 12 months, then taxane therapy. But if they had received previously a taxane and the DFI was less than or equal than 1 year, then physicians could choose between single agent carboplatin, capecitabine, or eribulin. And then I think also importantly in terms of the the overall design. So the primary endpoints were also different, right? So in ASCENT-03, the primary endpoint was PFS, and OS remained a key secondary endpoint. Whereas in TB02, there were two primary endpoints. The study was powered for both PFS and OS, and the statistical design allowed it so that the trial would be positive if either PFS or OS.
Now, in the more traditional kind of study design where you have PFS as the primary and OS as a secondary endpoint, in ASCENT-03, you mentioned there was crossover allowed, and patients were allowed access to sacituzumab after progression in the control arm. What fraction of patients was that in ASCENT-03, and what impact might that have on the statistical power to detect an OS signal, even if there might be one there?
That is a question, right? So we know that in TB02, of patients in the control arm so far, at least to date, at the time of the data cutoff, 30% have received any subsequent ADC in the control arm. So that is that's sacituzumab govitecan or TDXD or sacituzumab tiromatican. And so this is in the second line and beyond. Most patients in the control arm of TB02 have already come off protocol therapy. There are 2% of patients who still remain on study therapy. And the median follow-up was just over 27 months. In ASCENT-03, there were, in the control arm, about 14% of patients still on study therapy, and the median follow-up is around 13 months. And so in this trial, we know that about 53% of patients in the control arm have received SG, either as crossover therapy provided by the study or commercial supply, since it's available in second line and beyond in certain parts of the world. And but there's only data on SG, so we don't know yet if there's been any other subsequent ADC
It's a high fraction of crossover.
It is a high fraction, and it likely
contaminate the OS efficacy signal.
And it likely will continue to go up, right? The ADC rate will continue to go up with additional follow-up, perhaps in both studies as well.
Now let's talk about differences in patient population between ASCENT-03 and TROPION-Breast02. I understand that in one of the trials, the kind of rapid progressing triple-negative breast cancer patients who, let's say, relapse within about 6 months of completion of their adjuvant therapy, for example, those are often excluded, I understand, from first-line triple-negative trials. And yet, in the TROPION trial, those patients were actually allowed.
Yes.
Can you comment on that? And how does that change your expectations in terms of how sick these patients are, and about what fraction of those patients you think that would be?
Yeah, it's a very important point, the difference in the patient population between the studies. And so in ASCENT-03, patients who had a disease-free interval from completion of treatment in the curative setting of less than 6 months were not allowed on the study. And for TB02, they did allow these patients. There was a cap of 20% on the DFI of up to 1 year.
I see.
And what we saw is that in both trials, about 30% of patients have presented with de novo metastatic disease. About 50%, just under 50%, presented with recurrent metastatic breast cancer with a DFI greater than a year. And then that 20% in between with the early relapse. In TB02, most patients relapsed within the first 6 months of therapy. So that 20% was a distribution of 15% within the first 6 months and 5% with the 6 to 12-month DFI. And so that does suggest that it's a higher risk, poor prognostic group enrolled in TB02, and that could potentially impact, right, the outcomes, in particular also in the control arm, right, how the control arm might perform, right, in this patient population that we already know with early relapse, that outcomes with standard chemotherapy, unfortunately, are relatively poor with very short median PFS in standard chemotherapy.
And I understand stable brain mets were even allowed in TROPION.
Yes, asymptomatic stable brain metastases, and 10% of patients on TB02 enrolled with brain metastases compared to 5% in ASCENT-03.
I see. Interesting. Let's talk a little bit about the top-line data. Can we just start with response rates? What were the differences in the two trials with regard to the response rates? And in particular, what were the response rates in the control arms?
Yes. So in TROPION-Breast02, the response rate with Dato-DXd was 63%.
Impressive.
Exactly, and versus 29% with chemotherapy in the control arm, so more than doubling in the response rate. Now, I would bear in mind the control arm did not include doublet chemotherapy, so I think that's an important distinction with ASCENT-03, but still a 63% response rate in the first-line setting is a very robust, robust activity. In ASCENT-03, the response rates were quite comparable between the treatment arms, so it was 48% with SG, 46% within the control arm, which was, again, a mix about 50-50 between taxane and carboplatin plus gemcitabine.
Okay.
So I think those certainly there was a difference there, a clear difference in the response rates. I think this is actually a very important factor because this may be, and we'll talk a little bit about the progression-free survival and overall survival data, but this may be a determining factor for selection of a Trop-2 ADC, particularly for some patients. And so, the likelihood of achieving a radiographic response, complete response, the CR with Dato-DXd was 9%. I believe it was 54% of partial responses with Dato-DXd. And so, for example, with a patient presenting with liver metastases in whom obtaining that initial response is key, right?
Sure.
That may be a determining factor.
Okay.
What I do think was actually quite interesting is that the median duration of response was comparable for the two Trop-2 ADCs at just over 12 months, which is remarkable compared to the approximately 7 months of chemotherapy. And with the ADCs, we saw a significant proportion of patients who actually had durable responses beyond 1 year, which is truly remarkable to see compared to chemotherapy, standard chemotherapy for metastatic TNBC.
And then what about the time to event analysis for the two trials? Can you talk about PFS in both studies?
Yeah, so both studies...
I mean, that was the primary endpoint for, at least in one of the,
yes,
both trials, it was one of the primary
yes,
endpoints.
Yes.
In TB02, it was combined PFS and OS. Yeah. Dual
So,
primary endpoints.
exactly. So both studies met the PFS endpoint. So both studies met their primary endpoints. And the improvement, the hazard ratio in ASCENT-03 was 0.62. The hazard ratio in TB02 was 0.57. The absolute delta in median PFS was larger in TB02. So it was 5.3 months. 10.8 versus 5.6, but with the rounding, I think it's 5.3 months of a difference compared to 2.8 in ASCENT-03. And here, I think there's been there are a lot of considerations in terms of how the control arm performed in each study. The control arm in TB02 had a slightly shorter median PFS than that in ASCENT-03, and one might hypothesize that perhaps that's due to the differences in the patient population, right? But I think one important note is actually if you go to historical control and you think of the median PFS of standard chemotherapy for first-line PD-L1 negative metastatic TNBC, in KEYNOTE-355, the median PFS was 5.7 months, so not far from how the control arm performed in TB02. And so certainly what I do think was important to also note was that the 6-month PFS rates for both of the trials were relatively similar. But I think robust PFS benefit with the Trop-2 ADC in first-line setting.
I mean, I think the take-home message for our listeners is listen to your biostatistics professors. When you have different patient populations, don't just compare the Kaplan-Meiers side by side. Cross-trial comparisons are hazardous at best and probably shouldn't be done at all in this case. I assume there aren't enough events yet in ASCENT to talk about OS, whereas we do have OS data in TB02.
Yes, so ASCENT-03, this primary analysis was PFS analysis, and the OS analysis was intended to be descriptive. So the formal OS readout is not, we await the data. There were 37% of OS events in ASCENT-03, and at this early time point, there appears to be no numerical difference between the treatment arms. Yeah. The authors did present an exploratory PFS2 analysis that did show that PFS2 was prolonged in SG versus chemotherapy, but whether that will be a surrogate endpoint of OS remains to be seen. In TB02, with about 54% of maturity of OS events, the study met its OS endpoint with a hazard ratio of 0.79 and a approximately 5-month delta in median overall survival. And it reached 23.7 months with Dato-DXd, which when you think about that, that's 2 years compared to the historical 1-year median OS with chemotherapy that we saw a decade ago. So still much more work to be done, but significant progress
Yeah.
for patients with metastatic TNBC.
And that was statistically significant.
And that was statistically significant, yes.
Both co-primary endpoints,
Yes.
including OS. That's impressive. Now, what about safety signals? I mean, when we make treatment decisions in the clinic, we spend much of our time talking about anticipated toxicities and whether or not prophylactic treatments need to be given for various toxicities. How would you compare the two ADC molecules in this case in terms of expected toxicities and co-medications that might be routinely recommended?
It's a very important point. So what we saw between both studies was that there were fewer grade 3 or higher events in TB02 with Dato-DXd compared to SG in ASCENT-03. So there were about 33% of treatment-related AEs that were grade 3 or higher with Dato-DXd versus, I believe it was 66% of treatment-emergent adverse events that were grade 3 or higher with SG.
I assume much of that was probably hematologic in the case of SG. Is that right?
Yes. Yeah. So neutropenia, diarrhea, those were the main side effects with SG. And with Dato-DXd, there were 60% of patients who experienced oral mucositis or stomatitis, and 8% who had grade 3 events. 47% experienced ocular surface toxicity, also 7% grade 3 or higher events. But what was interesting, so most of the grade 2 or higher adverse events had resolved to grade 1 or baseline by the time of the data cutoff. Okay. And there were relatively few dose interruptions or dose reductions required because of those adverse events. Okay. And few ILD events, and importantly in TB02 there were no treatment-related deaths. In ASCENT-03 there was a higher rate of serious treatment-related AEs. Importantly, with both ADCs, the rate of discontinuation of the ADC due to toxicity was 4% for SG and for Dato-DXd in each study.
I see.
But with in ASCENT-03, there were 6 treatment-related deaths, all related to infection. 5 were in the setting of neutropenia in patients at risk who had not received prior primary prophylaxis with growth factor support. I see. As you know, the FDA label was updated recently, and it is very important to use primary prophylaxis with growth factor support in patients, at least in those who are at increased risk of febrile neutropenia. So growth factor support is one of those pre-medications or concomitant medications that we need to think about with SG. With Dato-DXd, because of the ocular surface toxicity and mucositis, eye drops, artificial tears, and a steroid-containing mouthwash are recommended as prophylaxis at least 4 times per day. Okay. And we do need to be very mindful always of ILD monitoring also on Dato-DXd, but again, there were few events on the study.
And the eye drops are not steroid containing; they're just moisturizing.
Exactly, yes.
Like saline-based eye drops. Okay, good. And the oral Decadron mouth rinse, is that effective in this case with Dato-DXd?
So it's a very good question, and we don't have data on that yet from this study, but it will be very important to look at the prophylaxis, adherence to the prophylaxis, and also I think the PRO component, the patient-reported outcomes, right, and differences if there may be in quality of life and certain measures that may capture some of these side effects that are experienced with the ADCs versus standard chemotherapy.
And were there not some PROs just reported today in that regard?
There were for ASCENT-04, right? So for SG, yes. Great. So for ASCENT-04, which was the phase 3 study presented at ASCO earlier this year, comparing SG plus pembrolizumab to chemotherapy plus pembrolizumab for first-line PD-L1 positive metastatic TNBC. So there were PROs that were reported, and interestingly, so they looked relatively similar between treatment arms. Yeah. Except when in the individual domains, I believe emotional functioning and pain favored SG versus chemotherapy, but then for specific symptom domains, such as diarrhea, for example, that clearly that favored chemotherapy versus SG, and I think that just underscores the differences in the prevalence of higher grade toxicity.
And the emotional, improvement is that probably because they're responding higher rates, et cetera?
Perhaps.
Longer time to progression.
It's a great question.
Now we have these two ADCs, both target Trop-2. They have different payloads. Assuming they both, achieve all the regulatory hurdles required this day and age, and maybe some acknowledgement from NCCN to get insurance authorization, et cetera, how are you going to choose between the two?
That's the question of the hour.
Yes.
I think there are a lot of factors to keep in mind, right?
Okay.
I think both ADCs show consistent PFS benefit. Dato-DXd has overall survival advantage. The data for SG are still immature, and
Okay.
crossover might impact that.
Right.
The higher response rate with Dato-DXd, I think that's an important factor to keep in mind as well when we think about selection of the ADCs.
Okay.
And then the difference in the toxicity profile, right? The fewer grade 3 or higher adverse events with Dato-DXd. But there are, there are the concomitant medications, the prophylaxis that needs to be discussed with patients as well, right? And
Yep.
the expected toxicity profiles. I think one important distinction also between the ADCs is that SG is dosed twice in a 21-day cycle,
Sure.
and Dato-DXd is dosed once. And also the actual total short infusion time between administration and observation is shorter with Dato-DXd than SG.
I see.
So these are all important factors to keep in mind when making a decision. I think ultimately sharing this information and making a shared decision with patients will be key.
I see. Any other nuances or factors that distinguish between these two molecules in your view that maybe we haven't covered yet?
It's a very good question. I think they both carry topoisomerase 1 inhibitor payload. They both target Trop-2, but we're all eager to identify biomarkers of response and resistance to these ADCs, and how can we overcome that resistance, right? How can we further improve upon these outcomes? And so very eager to see data from tissue blood samples, from trials that are ongoing, looking at these ADCs and how can we potentially overcome resistance to antibody-drug conjugates to help inform the next strategy, right? How can we further improve? And there's still many unanswered questions from the studies, right? For example, we talked about the hormone receptor low, HER2 negative breast cancer patient population. Should we extrapolate findings there? I think the CNS disease is also underrepresented in the studies, and no data on active CNS disease or leptomeningeal disease. So these are important factors. But I think one also very important consideration are the about 10% of patients with metastatic TNBC who carry germline BRCA or PALB2 mutations, right?
Yeah.
Because here we know that a PARP inhibitor not only improves median PFS, but also quality of life compared to cytotoxic chemotherapy. And there was the exploratory analysis in Olympiad of olaparib versus chemotherapy that showed that in patients who received the PARP inhibitor in the first-line setting, that there could be a signal of improved overall survival as well with the PARP inhibitor. So I think understanding a little more about the patient population who enrolled in ASCENT-03 and TB02 who carry these mutations and how the Trop-2 ADCs perform will be one very important question for these trials. To really understand whether we should be prioritizing Trop-2 ADC versus PARP inhibitor. So these are some of the important, I think, questions, but also looking very carefully at the impact on quality of life.
Sure.
I think this is crucial, right? Because ultimately the goal is not just to prolong survival, but to do so without compromising the quality of life of patients.
Now, let's say you have a patient who's on one or the other of these two Trop-2 ADCs, and they just aren't tolerating the one that you have chosen initially, and the toxicity is unbearable, and you're just going to have to stop it. Can you just switch to the other one?
Yeah. So we now have data with both, and so if there's significant toxicity with one, I certainly think it could be reasonable to consider switching. It's always to have options. Is a good thing, and I think it'll be very important to talk through these options with patients and to make informed decisions in an individualized manner.
Finally, I just want to touch on this OS issue once again. In other areas of breast cancer research, the OS has actually played a fairly significant role in the choice of which of, let's say, more than one choice of drugs within a class that we use. For example, first-line CDK4/6 inhibition in hormone receptor-positive metastatic breast cancer, the ribociclib plus AI first-line trial had an OS benefit that was statistically significant, while the other two CDK4/6 inhibitors failed to achieve that goal, although the abemaciclib trial had a p-value of 0.06, so it was a really close call. But in as much as guidelines committees like ASCO and NCCN and ESMO, they use not only the robust nature of the efficacy signal, but also the level of evidence of that signal. So is that going to play out here, do you think, that the OS that we already have in TB02, that's done. It's statistically significant. And that's the holy grail in solid tumor oncology, is level 1 evidence of an OS benefit with statistical confidence. And we may never achieve that with the ASCENT-03 trial because of the crossover. So is that going to be a distinction in terms of guidelines?
So that is also a very important question, a very good one. And I think, so we have to think about it also in the context of the breast cancer subtype. And this is metastatic triple-negative breast cancer.
Yeah.
And unfortunately, we know that about 25 to 30% of patients diagnosed with metastatic triple-negative breast cancer are no longer alive at 6 months for their metastatic diagnosis with standard chemotherapy. And so a medication that is able to significantly prolong progression-free survival with an acceptable toxicity profile should be sufficient to change the current standard of care in the first-line setting, irrespective of OS advantage. And I think both studies met their primary endpoints. And there are going to be limitations in the interpretation of the OS data from ASCENT-03 because of the crossover.
Right.
But I do think that including the crossover was a very important consideration. The drug SG is approved in the second line and beyond, but about 2/3 of patients enrolled in the study were enrolled outside of the US and Canada and Western Europe, where there is more limited access to these agents.
Okay.
And so there were the ethical considerations as well, right, of including the crossover therapy. And so it's going to be very hard to to compare the OS data between the studies, given the high crossover subsequent ADC rate use. So it'll be important to see how the guidelines list these agents. But I think that essentially both studies have demonstrated that Trop-2 ADC significantly improves outcomes in the first line setting compared to chemotherapy. And this is really changing the treatment paradigm of metastatic TNBC. And it's the outcomes, the improvements in outcomes. I think the data that we saw from TROPION-Breast02, very consistent PFS, OS benefit response rate, and the consistent benefits that we've seen with SG for PFS as well. These all support prioritizing the Trop-2 ADC in the first line setting, right? Okay. Because given the poor prognosis in this patient population, we should prioritize the Trop-2 ADC.
Certainly. Thank you so much. This has been excellent. Congratulations on your research in this area. And finally, it's having an impact on our patients with metastatic triple-negative breast cancer. And we hope that our comments will be helpful to our audience. And thank you so much for taking time out of your busy schedule here at ESMO to talk to us about these important studies and really breakthrough research presented right here in Berlin.
Thank you so much for having me.
It's been a delight.